All right, great. I'll give it a second before we actually open. All right, I'm going to start it, but only on paper. All right, here we go. Hi, folks. We're going to give it a moment or two while everyone comes in from whatever they were doing previously. We know that you all are very busy, so we're excited that you chose to spend an hour with us. If you'd like to introduce yourselves in the chat, that is always welcomed. It's nice to know where folks are coming from, their roles. Feel free to use the chat for that. Like I said, we'll give it a minute, let everyone take a deep breath and get settled in. Again, we're excited that you're with us today. Yes, we have a welcome message in the chat. Thanks, Katie, for kicking us off. Please do in the chat note that you can either send messages to the host and panelists only or everyone. So it's great if you would select everyone unless you have a question for us, which then of course you can go ahead and do that. Hi, Peter. Nice to see you. All right, great. Just for the sake of time, we will go ahead and get started, but I believe that we'll have more folks join us. And yes, we will. Yes. All right, great. So again, hello and welcome. As folks are still coming in, we are really excited to spend an hour with you all today talking about person-centered approaches to addressing substance use disorder in older adults. My name is Ariel Mather, and I am the program manager of the National Center for Equitable Care for Elders. And thanks again for joining us today. Thanks to those who are introducing themselves in the chat. All right, so we all are very familiar with Zoom, but I do want to mention that because this is a webinar format, everyone is muted to prevent any background noise. We would love if you continue to use the chat or the Q&A feature to pass along comments, questions, concerns to our guest speaker today or to the NCECE team. Feel free to do that. The raised hand option is still available to you during discussion at the end. We could potentially take folks off of mute to ask questions, but please do for now use the chat and the Q&A. This session is being recorded. We want to make sure that everyone who registered who may not have been able to attend live and those who did have access to the recording and the slide deck. So be on the lookout for that. And as always, at the very end of this session, we'd love for you to fill out a very brief survey that helps inform our future training and technical assistance activities. All right, so if you are not familiar with NCECE, welcome. If you are, welcome back. We are a training and technical assistance provider funded through HRSA to give health centers and community-based organizations resources and training around the health and well-being of older adults living in their communities. We'd love for you to stay connected with us. We have a lot of social media platforms linked here on our website, which I believe Tiff will put in the chat. We have another webinar coming up in early May on the environmental impacts on healthy aging. Would love for you to join us for that. So if you're on our mailing list, you will see a few more reminders, but please do stay in touch with us. All right, so we are going to have you all give us some of your insights and thoughts in just a moment, but just to very quickly level set, you saw these learning objectives when you signed up for this session, but we are wanting you to walk away from this webinar today feeling comfortable, understanding some of the common misconceptions around this topic, substance misuse in older adults. We're going to talk about both benefits and limitations to screening tools for this concern, and then hopefully have some shared strategies for intervening services, all of that for specifically for our older patient population. Great. We're going to go ahead and use one of our favorite tools to have you all share with us. This is Mentimeter. If you've joined us before, you may have been familiar, or other webinars, feel free to scan the QR code with your phone. You can also, on your computer, go to menti.com and use the code 54805473. Thanks to those who are continuing to introduce yourselves in the chat. Mentimeter is going to give us a chance to visualize a little bit where folks are both coming from and what they hope to take away from this session today. I will say, if you are having a hard time connecting to Mentimeter, you can feel free to put any responses to the following prompts in the chat. Yes, slides will be available. We will make sure all registrants and attendees receive a link to the recorded session as well as the slide deck. It will also include the Mentimeter responses, so that's hopefully will be helpful for folks. All right, I see lots of little thumbs up in the corner. We're going to start with a little map. Sometimes the pins can be a little funky, so do the best you can within Mentimeter to click on where you're joining us from. It's nice to get a visual. Again, yes, if Mentimeter is giving you a hard time, please do use the chat if you haven't already told us where you're coming from there. Always nice to see little pins pop up. Give it a second. I see in some of the intros you shared where you're from. Yes, Missouri, great. Lots of East Coast representation. Illinois, great. Thanks all for sharing. Welcome, welcome, yes. Thanks all. All right, let's just for the sake of time, go to, you basically gave us some of this in your registration responses, but I'd like everyone to be able to see all at once kind of what you're hoping to take away from this webinar. There's no wrong answers, so please do just type in what comes to mind, either in Mentimeter or in the chat. Knowledge is absolutely a good goal here. Ideas on how to start conversations with patients. Yeah, absolutely. I love that. Lots of knowledge. Yeah, hopefully you'll walk away with a good amount and good resources to look into after this session as well. Greater understanding, unique challenges that they might face, for sure. How to apply it. Absolutely. Yeah, we have a lot of folks, I think, in a lot of our activities that want to share information with their team, and that's fantastic. We hope that this is useful as you're going back to where you practice, where you work, and sharing this information with others. I feel like this isn't discussed enough. Yeah, absolutely. Absolutely. Thanks all. That's really great to be able to get a visual. Ditto on all. Great. All right, let's go to the next prompt. All right, this is going to show up as a word cloud. So I want us to think about, in just a few words, why some folks acknowledge that there is a lack of attention on this topic. Why do we think that? In a few words. Oh, yes, things will, as more responses come in, the ones that have more than one responses will start to get bigger. That ageism, stigma, lack of media coverage, denial, isolation. Yeah, stigma still right in the center there. This is great. Thank you all. Give it a second. Isolation, stigma, ageism. It's a tough word cloud to look at, but I think that we see the commonalities in what folks are thinking and their experience on maybe the lack of attention or understanding that this topic has. Thanks, everyone. Really appreciate your responses here. All right, let's quickly go to the next, just because I want to leave as much time For our speaker, all right, so this is a scale exercise. So you can see that on the left-hand side is strongly disagree, on the right is strongly agree. So you're able to drag along the line under each statement. So you can pick anything between 1 and 5, and it will start to average based on everyone's responses. So you'll see this start to really move around. So the first statement that you're responding to is drug and alcohol screening tools are sufficient for identifying substance use disorders. So you can be on a scale between really disagreeing or really agreeing with that. Then there are a couple more personal questions as far as your own role or location. I feel comfortable discussing substance use with older patients. And then there are adequate services and resources in my community to address substance misuse in older adults. So you can really see the variation here. I'm glad to see that the comfort level is higher than some of these other ones. So I'm glad that folks are thinking about it and want to have those conversations. I see some mixed results on how effective screening tools are, and we will talk about that. And then as far as what's available in your communities, that's definitely low. And obviously it's going to really vary from location to location. So maybe if you have some questions or concerns related to the availability of resources, we can bring that up in our discussion towards the end of the session. So really appreciate everyone's insights there. Thank you so much for participating in that. All right, I don't want to take up any more time away from our wonderful speaker today. We are very pleased to have with us Dr. Stephen Martin, who is a professor of family medicine and community health at the UMass Chan Medical School, where he is residency faculty and co-directs the Rural Health Scholars Program. He's board certified in both family medicine and addiction medicine. His clinical and research interests include primary care, oral health, complex care, addiction medicine, chronic pain, diagnostic error, and health disparities. He's also the lead author in publications in the BMJ, JAMA, Lancet, Annals of Internal Medicine, and the American Journal of Public Health. So Steve is really passionate and knowledgeable about this subject, and we're so fortunate to have his insight and expertise today. So please, during the presentation, we're actually going to switch screen shares at the moment, so this is a good time to do that. Please do share comments, questions in the chat or the Q&A. We will definitely save some time at the end to discuss, and if anything is pressing, we can certainly pause and visit those questions in real time. So thanks so much. Go ahead, Steve. Oh, you're still on mute.
There I am speaking again. This is how I show off with getting started. And for those who thought that Steve Martin, the more famous version, might be here instead of myself, I'm sorry for the disappointment, but I am wearing almost the same tie as in that photo. So I feel like that's good karma also. I am really grateful for this chance to spend time with you discussing what I think is as you mentioned in the word clouds and otherwise a fairly sadly overlooked part of the American landscape, and one that I'm actually very humble about in terms of what we know in terms of research, but also what we know clinically, and will be especially grateful if you might share in the chat your insights or resources that you love, and we can then share the chat with folks afterwards with the recording, because if there were a perfect way to help older adults with substance use, we would be talking about that way. But unfortunately, to my knowledge, we don't yet have a situation where that's possible, and we need to find the right excuse me, the ways that are best for most people. And I'm sorry, I'm just looking here real quick and we'll share my slides. And as folks asked, those will be available for sure for afterwards. And let me just bring the right one here. And my screen sharing is paused. I don't know why that is. It's being mean. But Ariel, please feel free to share if that's okay. I'm sorry I can't
Okay, yeah, no, give me one
resume
moment.
share. No, it's just not, it's being very mean.
Okay, if you want
Making me look
to,
bad. Yes,
no,
but I,
if you want to
yeah,
stop screen sharing,
yeah,
okay, I will get those up. Give me
very good.
one.
We will prevail. And Ariel can solve anything from what I know personally. And I'm just grateful again to the National Center for making, focusing on elements of care that aren't necessarily um well in hand or established and yet are incredibly important to people. So Ariel, thanks for your help. And I'll just say next, please, if that's okay. So I am a medical director for a telehealth company that brings care to people mostly with Medicaid around the United States, and also a medical director for a residential site, as well as mostly being a family doctor in the rural each day. And my views, though, are my own. Next, please. Um, so this is a repeat of the great thoughts that were already shared in the learning for today. So thank you. Next, please. Um, I would say this is probably one of the more important slides to share, um, in that um, we live in an age where we have an incredible armamentarium of prescriptions and medications and interventions, but I can't think of an area that's as idiosyncratic and as important for individualization of care than the one we're speaking of today. So substance use and mental health are so highly stigmatized and a burden people feel, that their own experience with these conditions sort of shapes how they may interact with you or the clinical team about them. And also, to be honest, we've done a pretty horrific job and over the history of medicine and how we've cared for people with substance use disorders, whether we were called them morally flawed or feeble or had alcohol asylums. I mean, these are within the past 100 years. So it's not as though we've become enlightened quickly. And sadly, there's still quite a bit of stigma within the professions, within all of our professions still. Next, please. So this is a case that's active currently. I'm rounding in the hospital this week. And so this is a patient that we admitted on Monday. He had rectal bleeding and was found to have a platelet count. That's sort of the sticky things in blood that keep clots together, that was really low. And also an INR, which is sort of how you coagulate blood, that was higher than you'd think. Both of these are signs of cirrhosis. And he also, with ascites, means that this is sort of decompensated cirrhosis. He reports 6 or 7 drinks of vodka a day, and he's sort of pre-contemplative when he's come in to see us. And he hasn't really tried stopping before, but his imaging, his signs here on labs all are comport with a diagnosis of cirrhosis. And if you're on the team caring for him, number 6 will be, how would you play some chess in terms of thinking about opening up a conversation? Would you do that during a hospital stay? Would you try to find out who's in his life? Like, what are some strategies that you might use? Again, remembering that this gentleman came in for rectal bleeding. He did not come in to discuss, drinking that has likely led to alcoholic cirrhosis and hepatitis. So I'd be grateful if in the chat you could just sort of share ideas that you have, so that we can all benefit from them. There's not a right answer here, but there sure are insights I know around the table that we're at today. And please just continue to share those throughout, so we can learn from you. Next, please. So I'm taking a step back here regarding what we consider to be substance use disorders. And this is actually my father's father's autopsy from 1986. And he often always had a parliament in his hand, cigarettes, and was a terrific grandfather to me, and had a use disorder, in this case, a nicotine use disorder that led directly to his death from from lung cancer. Um, and I've had other relatives who have sold silver for alcohol and, lie to their loved ones about their drinking. It's just really hard to find a family that isn't influenced somehow by substance use disorders and the really negative consequences they have not only for individuals but for their loved ones. So please know I'm keeping this very much in mind, and I don't mean to not address um, tobacco, for example, which I'm not looking at as much today here, but recognizing that this spectrum has an enormous effect on elders in our communities. Next, please. So this is, reached somewhat of public recognition over the last 2 to 3 years, where during COVID and the pandemic, there were sharp increases in isolation has been mentioned in the chat, anxiety, sometimes fraternal or getting together, that led to rapid increase in drinking that we saw in volume sales. And that substance use or abuse, they haven't used the right term here yet, but in the New York Times, they got to get better. But the substance use is growing in the senior population. So next, please. And this reminded me to really come back to think about what are what are the substances people are using. And this is a bit of an old slide, but I think it's still the best representation. Here we have alcohol and opioids being really overshadowed by tobacco. And the number of deaths from tobacco each year has stayed fairly steady at about 450 to 400,000 per year. These are legal substances, and alcohol is really what I appreciate focusing on here today, because it's it 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 has it is the substance that most affects day-to-day living for elders and contributes to active harm during their lives. So next slide, please. And next, thanks, the little animation here. But just to consider, what do we think are sort of dangerous drugs? Alcohol remains at the top because it has this really unfortunate and tragic element to it, that it causes harm not only to the person using, but also to others in the community, whether that's through violence or trauma, whether it's through motor vehicle accidents, whether it is through interpersonal violence. Alcohol really, unfortunately, has the firm upper hand here in terms of danger. Next, please. Thank you. And I'm thinking now of our elders, and I'm getting there myself, but older patients, have lived through an arc of time where even drinking and driving was relatively normalized. When I was growing up in the 70s, there wasn't Mothers Against Drunk Driving in the way that it is now. There weren't laws that were highly punitive for repeated operating under the influence. And so our older patients have had to adjust if drinking's been part of their life. They've had to adjust, just like they've had to adjust to tobacco being much more excluded from public sphere. Next, please. And if there are any sort of impressions when you look at these set of images, alcohol is in every nook and cranny of the American cultural experience in the 2000s. The number of signs and T-shirts, the number of apps you can have to just deliver to your door. This is an incredible shift from relatively restrictive practices going back in time, certainly with prohibition, where the idea was to completely restrict alcohol. We're now in a state where alcohol has not been taxed generally in the past 20 to 40 years, and anything commensurate with its growth and cost of living, where it's more accessible, and where, as you can see in the middle slide, the use of alcohol has been really made commonplace. And it's seen as sort of a pretty reasonable way to help your mood, help you get through the day. Um, and again, I'd love your thoughts on if you see how you see this in your part of the states, and grateful for people from all over the country. But it's hard to think of a substance that has gained in traction over the last 20 years that's illegal. And that would be alcohol. Next, please. How much do Americans drink? Well, this is again sometimes a remarkable slide to think about, but it's the top decile of people who are drinking on the order of more than 70 drinks per week. And if next, please, that is it is essential to the industry that those people keep drinking. So in the third paragraph, as you can see here, if you consume 10 or more drinks a day, the beverage industry is heavily dependent on you for their profits. So there's not a lot of counterweights to people in our culture to drink less. Certainly not from industry. What we see is a lot of drink responsibly, which is sort of a vapid, empty instruction to people. Where when clearly if people have a substance use disorder, it's not entirely within their uh, conscious self to drink responsibly. Next, please. So this is the part, and I saw this as sort of takeaways that people were hoping for, and I was grateful to review just some of the epidemiology. I want to focus mostly on what we do with individual patients, but the two-thirds of folks who are older, over 65, and have a disorder, they really generally began this, as people have noted, substance use disorders are a condition of adolescence. And so it's only a third of folks who began their substance use after that time of their lives. Next, please. And just to put, some numbers, these are, again, relatively older numbers, but it's hard to get really good data. This gives a sense of proportion, though, that in 2014, close to 1 million older adults had an alcohol use disorder, and about 160,000 had an illicit drug use disorder, such as cocaine or opioids. And you can see that sort of ratio is not quite 10 to 1, or 9 to 1, but it is substantial in terms of how alcohol is overwhelmingly present in people's lives, in terms of as a substance for older adults. Next, please. We've also seen a rise in drug overdoses for older adults over the last 2 decades, which has been growing fairly consistently, and still relatively low overall to the overall population. This is about less than 1% of overdoses in the US are from older adults, but it has been rising and capturing more of the proportion. Next, please. So next, just I find myself repeating this, and again in the chat, please share thoughts. I see it's been Peter and Laura were there a little recently, and all the other great people, but please keep adding ideas. So alcohol is really the most widely used substance, as we just saw, and this is to bring back tobacco again, though. Of the 480,000 tobacco deaths that we're up to, 300,000 are from older adults. So something one might expect, and it's these last two that I think have us reaching for each other as colleagues, and having a willingness to learn all different facets of care, because it's unusual to have these two last bullet points. So opioid use disorders, alcohol use disorders worldwide are the second and fourth most stigmatized health conditions. That has incredible and devastating repercussions on how people approach their lives and how they approach their addiction. And to have that occupy less than 1% of all primary care visits is such a mismatch. There's so much morbidity underway, and primary care does see a lot of older patients, but the substance use part of people's lives is rarely addressed for reasons that go back to stigmatization, and also a worry or concern, I imagine, on the part of patients as to how their healthcare provider will react to their discussions. So next, please. All that said, and Katie makes this point very well here. Um, Seniors' use of substances and developing a use disorder is accelerating. And it's not, though, clear to me that the demand for substance use disorder treatment will also grow. That is, very few people actually seek treatment compared with the iceberg below of the water of people who actually have a use disorder. So it would take some very different efforts on the part of healthcare to, one, destigmatize as much as it can these use disorders, and two, create environments that are welcoming and appealing for people to take part in, to help folks get better, while also relying on mutual aid such as Alcoholics Anonymous or Narcotics Anonymous or Smart Recovery, or Dharma, which is Buddhist in nature. There are lots of mutual help uh, groups that have good data for helping people in the community in ways that I can't do as well as a physician. Next, please. And so we come to the crux of the matter. This is an article just from last year, a 2-page article. And I always look at articles like this. I'm like, what can I learn from this? Please tell me more about age-friendly care. And yet the article doesn't actually sort of ends with sort of a, we need more understanding of how to do this. Well, so I can't imagine there's a bigger group in the country right now of people trying to think about this than the folks on this Zoom call right now, because you each have a strong interest in this care. And yet what we're trying to wrestle with is a set of systems that will have to be built or adapted to meet the needs of older adults. Next, please. And this is sort of been our typical way of thinking about care for geriatrics, for example, is sort of what's been called the 5 M's. The mind part being understanding people's cognition, their mobility, their gait and fall injury risk, their medications, and all the harm that can come from me prescribing too many to a given person, or the wrong not prescribing a given medication. Multi-complexity on the left, which is, the dynamic that we see, much more with older adults, because we're all accumulating conditions as we get older. And what should be really the biggest one is that the bottom here is what matters most. And I think that's Katie, thank you for this again. And Aaron, what matters most for people may not be abstinence. And our reflexive answer to each person's condition with the hammer of abstinence is not useful. And I think in general in healthcare, we have a really distorted sense of the kind of control, quote unquote, we have over other people, that people, have their own understandably goals and desires and our agency. And understanding what matters to folks is paramount. And then that is possible, though, in a motivational interviewing mindset, to sort of frame what people value in a way that illuminates perhaps the kind of risks or harms that they're currently experiencing. Next, please. So what I like about this photo, coupled with the text on the left, is seeing people, and seeing people who are engaged and in an attractive setting where they're getting better. And I'm very agnostic and ecumenical as to what those settings can be. But we do not have a lot of places in our communities where folks who have the struggles that we know of are able to lean on knowledgeable people like yourselves to help them get better. Next, please. So I've come to think, and this is where the chat, I'd love to light it up also. I I know one of the learning objectives is screening, and certainly the audit, which is an acronym for one of the alcohol screen tests, is probably the most accurate and deployed, or audit C, which allows you to ask just a couple questions as a screening test. But I just want us to remember that with highly stigmatized conditions, people will give a similar response to what I might give my dentist, which is, of course, I floss every day, um, and sort of give a socially acceptable answer. It's hard for people to reveal things that they themselves are either scared about or are concerned will lead to some sort of bias. And um, use disorders are at the top of that list. Uh, so I like the idea that we can create sort of soft power or soft messaging that doesn't isn't a direct experience a person has, but is done with the intent of reducing barriers to care. So we have lots of signs in healthcare, right? Please get this screening test, or you could get this vaccine, or talk to your, clinician about X. But I have rarely, if ever, seen signs for folks saying, are you concerned about your alcohol use? The people here in this building are ready to help you, and care deeply about you. Like, those messages are ones that uh, uh, cannot be overdone. They've been so poorly done over the years. It's time to have a counterweight. And would be remarkable for people. I think many people don't know, including myself, until this kind of work. uh, People don't want to go to a detox necessarily, quote unquote. They don't want 2 or 3 weeks away from their families or jobs they may still have. They don't want to answer questions about where they've been. But 80% of people who drink and are concerned about substance use disorders, 80% can have a withdrawal management in the outpatient setting. And this deserves to be on one of those signs. And we'll look at sort of the criteria for that to happen. But I think this allows and lowers the barrier for people to come off alcohol safely in the outpatient setting where they have their other supports. And of all the things I could recommend, I would think that cultivating the ability to do this well would be right up there. Next, please. I think partnerships with other trusted entities in our communities, whether that's the Elks Club or the Rotary, whether it's houses of worship, whether it's other, the local sports teams, or golf teams, or take your pick, garden clubs, like, having those folks in working with us in synchronicity can only make our work more apt. And certainly there are dedicated places to elder care, such as senior centers or PACE programs, where collaboration could be incredibly helpful. So you're seeing here, I asked that initial question, how would you help this gentleman uh, begin a conversation? I'm not, these are areas that make that conversation more easily done and pay off dividends for, entire groups of people over time. Next, please. There has been, as you all note, and a dry January has been building in popularity. There are also sober bars now, and where people have non-alcoholic drinks, which I think is a welcome event. And there are other community ways of building community of people who prefer not to have a drink all the time. And the most potent individuals I've seen in terms of their superpowers in helping people have been peer recovery specialists. And here's where we can tap the knowledge and wisdom and collaboration of people with lived experience in the older adult setting. And sometimes talking with Steve Martin is not the best thing. Often it isn't for a given person, but talking with someone who also has struggled with a substance and has insights and is unconditionally supportive uh, is a game changer for people. Hence, it gets a orange color from me. Um, Speaking in the community, including people from the healthcare workforce who have either family or themselves had conditions with substance use or concerns is, again, a normalizing and destigmatizing act. And I appreciate any other ideas people have used in their communities in the chat to sort of get a sense of these were ones that I've been cultivating, but I'd love to know and learn from others here. Next, please. So just speaking directly for, yes, Natasha, we're all aligned. My gosh, it has been, like I mentioned, a superpower that I've found so illuminating and a part of the healthcare team that has been missing, just absolutely missing for decades, forever. And it is a triumph to see people lend each other a hand. Um, and as long as we are also treating them absolutely as peers, not only to our patients, but our peers, and they're respected for this vital work. So, uh, because as we see in that list, alcohol or other use disorders are less than 1% of primary care visits. Often the ways those conversations start is because something happened. Someone developed an injury. I remember a patient about 10 years ago broke his ankle, and that was what led to a discussion about his drinking. Um, Someone gets an operating under the influence, they are required to come see me or someone else and discuss their substance use in a respectful way. Next, please. I think that, we see patients frequently, for example, for their blood pressure or mood, certainly for people with active cancer. But considering how substance use can affect people, this is also an area where frequent visits are both reinforcing, if they're not annoying, and also convey a sense of, our interest in this care. Next, please. And someone mentioned earlier the isolation people can feel, but if there is someone in somebody's corner, one of my favorite questions to ask because it's illuminating, can you tell me, who's in your corner, who looks after you, who gets what you're going through, who do you feel you can open up to? And those first names are like gold. Uh, and if there's really no one, then we also need to know that, because there's a perfect place for a peer to help out, and recognizing that isolation is really critical. And then thank you so much for the NAMI. Yeah, there is pharmacotherapy, whether it's in the form of a camprosate or um, disulfiram or naltrexone for alcohol use disorders as FDA approved ones, and gabapentin and topiramate is other ones, and certainly glad to share those resources with you and not a bunch of dosing here. But even what's called the Sinclair method, which is to take naltrexone as needed. So if one is to go, coming to a gathering or a sports game where there's likely to be alcohol, you could take naltrexone on an as needed basis, and it does reduce heavy drinking and binge drinking. Next, please. So these are lists, and thanks for coming through them, Ariel. Yeah, just to give folks a sense of the factors that contribute, and the person we're working with in the hospital currently. I'm sorry. Yeah, thank you. He lives alone. We don't really have someone else to reach out to. He seems a little flat, although he has a lot going on. And but these are conditions and experiences people accumulate as we all get older. And I think boredom also is a key element to think of. You probably have met people who've retired and then start working again because, being at home didn't turn out to be the kind of experience they thought. So I think just having this list in our heads about what are remediable parts of people's lives that can add life and detract or pull away from the appeal of a substance. Next, please. And so I wanted to include again these variety of ways of very practical ways of helping people with at-risk drinking. And these are actually Canadian, I believe, and they're really well put together. Committing to a goal can be useful for some people and not others. I like the idea of emphasizing that people's energy and sleep and mood can all improve markedly with reducing drinking. Blood pressure is always a classic. That also will improve. People's weight, you think about the foods that we have in the US. The only major one that does not have a calorie label is alcohol, because the alcohol beverage industry has resisted placing the calorie sticker on every single bottle, because people would understand that you can put on a lot of calories just with a few drinks. Um, and thinking about triggers, I think that people can, they often can find something that really puts them in a place where they're more likely to drink a greater amount. Next, please. Similarly, this is sort of strategies to avoid intoxication, um, like sipping drinks. I have a patient who, when I asked, how many drinks he has per day, he said, I have 7 glugs. And a glug is, from the vodka bottle when you tip it, and then the air comes in and makes a glug sound. So, having people find sort of behavioral techniques to limit their intake. And I love this timeout idea, which works for many things that, something I wish it would work for me for ice cream, though I love ice cream. But taking that time out, letting your brain pause for a moment, and also uh, the dilution of drinks, where you're just cutting into the proof that can be really hazardous. Next, please. And this loops us back a bit to home management of alcohol withdrawal. And I have a set of references here where you can get the actual protocols. But by asking people if they have, do you have a history of severe withdrawal? And that includes seizures, delirium, or hospital admissions. And they don't have hepatic decompensation is noted here as well, they are likely eligible to have an alcohol withdrawal management at home through the use of either a benzodiazepine for several days, or gabapentin has also been found to be effective. So, and then some frequent follow-up with the person and their supports. I just think this gives someone a choice in their lives. It gives them agency to do something most everybody doesn't know about it. But I think it's actually sort of a liberating possibility when people feel like they're stuck, and they can feel themselves withdrawal when they try to stop. And that is a barrier for many people, understandably. Next, please. So in summary, uh, as with other conditions, trust and especially in communities, and the expectation of confidentiality, given the risks people face, are really often required. Next, as has been brought to our attention with harm reduction, any positive change matters. And if we had a magic wand, we would absolutely use it. If the person with the use disorder had a magic wand, they would use it. People do not like uncontrolled, chaotic use, and that's often when people are in the throes of a really tough situation. I think that, as I mentioned earlier, with sort of these cultural ways that we can convey support that are nonverbal, and also make public sort of different ways of addressing people's concerns. I haven't gone through opioid use disorder here, which is much of my practice, and it could be used as easily for that. And certainly having someone get on buprenorphine or methadone would be job one in terms of protecting them, having them have access to Narcan, to not using alone. So there are steps that can be taken for both of these major use disorders, opioids and alcohol. And then try to figure out who's on this person's team, both their home team, but also, I hope, their peer team. And coming back in a year is not a great follow-up for this from a healthcare perspective. And so conveying your interest in this through the kind of intensity and frequency that you offer is a real marker for people as to how much you're on board. So next, please, if I could, and we can just sort of go through these, Ariel, quickly, and I look forward for any discussion. But I put references here at the ends, and I found that the ones in orange are especially good. And so it's been cultivated a little bit for you here, including a number of webinars and practical protocols. And lastly, at the end, you'll find this writing in for a book called Tiny Beautiful Things, which was written by Cheryl Strayed, who also wrote Wild. And this letter, this is from someone struggling with alcohol use in a rural community. And then her response in the next 3 pages is one of the most empathetic uh, connections I've seen on the printed page. And it really, for me, puts meat on the bones of how these conversations can unfold and the kinds of risks people are taking to try to get better. So thanks so much for spending time with me here. And I'd be grateful for people to raise hands and share themselves, their ideas and approaches to the work, so that we can learn from you. And thank you so much again.
Wonderful. Thank you so much, Steve. That was really wonderful. Thank you so much for all the resources as well. I know we had some folks offer some of their insights as we went along, but I want to give folks a minute or two to be thinking about questions specifically for you. Okay, Tiff has a question. As far as
Yeah,
your
uh,
experience talking with older adults, do you feel?
sure. Sure. Well, I'm a little torn here because a lot of the work with our elders and older patients is comes from the disability community, and you all may have heard about it, sort of what's called the dignity of risk. And I'm not out for conscribing people's ability to do what they want as long as they're informed. Um, I would let people know that all of our metabolism as we get older in the face of high potency alcohol is pretty deranged, and things that you would never know, like your sodium starting to plummet, and that can lead to a lot of mental status changes and other significant effects. So I think it's worthwhile to say, okay, this is the time of your life. This is sort of a plan that you have. I care about you. I want you to be safe. I want you to enjoy yourself. So please know that with a couple drinks, you can probably have the same effect as now as when you were 20 and had 10 drinks. So I think that's a message that's worthwhile. I would also certainly have them reduce their risk to other people. This is a time to have someone else have your keys, and other forms of safety. And then follow it along. Like at the next visit, how is that going for you? Reaching out to their home team, does their partner or brother down the street know what you're planning to do and can sort of keep an eye on you? So thank you for that idea. But I think this idea of like respect for the person, respect for their dignity, but in an informed way that they have, like, there's likely information they may not know, and then the incredible effect from human connection.
Absolutely. We had a question around screening tools. I see
Yes, yeah,
Daniel.
yeah. And this is where uh, Tiff is such a genius at pulling up different links. So I think they're both they have high validity, both the MAST G and the audit or audit C. Um, I do have concerns about people not being, understandably, not being willing to disclose themselves having more drinks than they're putting on the paper. So, this is all within, are they valid? They have some validity. In the primary care setting, though, I think it's much trickier to get a handle on how many people are actually disclosing something new to you as their clinician or healthcare provider that you wouldn't get through discussing things with them. So, but going along with that, this is not screening. I think, uh, sort of case finding. If you had a person who earlier in their life had, difficulty with alcohol and found a way to help address it, um, that's a thread that you may want to pull on, not in a finger shaking point of way. Oh, thank you so much, Juliet. But just to recognize that this can be an ongoing struggle. And for legal substances like alcohol, you cannot get away from it. It is so pervasive that someone may be in a situation now where they feel more vulnerable to drinking at a scale that they hadn't before. Um, so I hope that helps with the question about screening. I mean, thank you so much for those links.
Wonderful. Someone is mentioning that in their location in Sonoma County, a lot of older adults find that they're overusing.
Yeah, yeah. Well, I think we haven't had a lot of luck with no use. Um, and there's certainly folks for whom that is exactly the right thing. And I just have to think this is not quite let a thousand flowers bloom, but having an individual, as we talked about earlier, having an individual meet with their goal and their method. I mean, this goes back to, birth control. What's the best method? One that someone will use and appreciates and likes. So, advising ongoing abstinence. When people leave my place here, I don't follow them home. I don't have, they have agency over their lives, not me. So I'm not interested in sort of fooling myself that by advising abstinence, I've convinced someone of something that they don't want to do. So I love this idea of like water in pretty glasses. I mean, it turns out that a lot of high level potency spirits are clear, so you can definitely work on that front. There's often sodas around or tonic waters and a squirt of lime. And I think maybe embedded in this also having friends that, especially in Sonoma, my God, I mean, you're in at ground zero, having friends support each other. If you're going to a party together, you have your buddy sort of get that drink for you that doesn't have alcohol in it or has much less than someone else might think. And so uh and I think people are being more vocal now about their limiting their drinking. And that is an empowering statement to say, look, I'm not drinking as much these days. Thanks for this small glass of a couple of sips of this delicious wine, but I don't need it anymore. And I think the idea of savoring the quality of something, but not the quantity, is something that many older people would understand.
Wonderful. I did have one question, as we're just waiting to see if there's any others in the Q&A or the chat. But we had someone in the Mentimeter mention specifically kind of wanting to walk away with understanding more around initiating the conversation.
Yeah.
Now, I know you've already kind of given some
Oh, no, no, no. I love
context
that
about
one. Yeah.
about messaging in signs and other things, and you've had some great thoughts around how you're responding to some prompts. But I'm curious your thoughts on that initiation.
Well, again, in the chat, please share your own. We'd be grateful. The phrases like "who's in your corner" are things I've learned from colleagues or people on the health team, other colleagues, right? And so a good phrase can be used as like a Swiss Army knife. Like you can use it in many different situations. If someone has a new cancer diagnosis, who's in your corner is a great question. So similarly with initiating here, I would say something to the effect of, and not a novel idea, but are there things in your life that you feel you don't have the kind of control over that you wish you had?
Hmm.
And that's a pretty generic question. That could be gambling these days. I mean, talk about other things that are now in every nook and cranny also of American life. Gambling is reached that level. So just keeping it open to whether it's a behavior or a substance are the things that are getting in the way that you'd like to live your life. And then sort of a stealth question, follow-up can be, if the person has a partner or a loved one, what would your loved one, what would they say? What do you think they would say? So often we need a way of sort of getting out of our own way of being to understand, and you're sort of creating that hypothesis for them. But no one is going to answer uh, truthfully if they sense immediate judgment and a harsh change in your relationship. And so everything you're doing up into that initiation also is makes the initiation real and authentic and trusted. And I think, again, I don't know how you all feel in healthcare, but we've sort of forgotten that people have to trust you to be cared well by you. And people are not widgets. So bringing your open self to these authentic healing relationships as you all do, that makes whatever next words come from your voice, that makes those next words trusted and listened to. And eye contact, please. And so this is more of like, how do you start a conversation? The last little part here, and we'll get the paper for you, but I was so distressed to find in a postpartum depression screening, clinicians are asking the questions, are not even looking at the patients. The patients are screening in for depression. They're not followed up with. And when we start to mechanize pretty deep things like depression and use disorders and don't really show care about what we're asking, that is a misguided and a terrible experience for patients. So just the focus, the attention that you all bring is as important as the words that you have.
Absolutely. I think that's a wonderful way to wrap up our session today. Everyone will receive the slides, so there's lots of good resources to take a look at there. We thank Dr. Martin so much for his time and expertise. We thank you all for sharing your own insights with us. We are here if you have other training and technical assistance needs. Please keep in touch. We hope to see you at another learning opportunity very soon.
Absolutely. Thank you all so
Thank
much.
you. Take care.